Hello, nice to meet you. Today, welcome to my video lecture. I am going to talk about tumor of the cervix. But in this lecture, we are going to discuss the epidemiology and risk factors, and I will describe the clinical presentation of carcinoma of the cervix, and I also will discuss the stages of the cervical cancer, and finally we will discuss diagnosis and management of cervical cancer. Epidemiology. They found that cervical cancer it is one of the most common cancer in women in developing countries, and it was found that it is the second most common form of cancer in women and world as a whole. The incidence of cervical cancer has fallen in United Kingdom by 44% since 1975, and this is due to the cervical screening. They found that the major risk of cervical cancer is human papilloma virus, because human papilloma virus is a DNA virus, and it was present in around 99.7% of all cervical cancer. Human papilloma virus is a family of over 100 different virus types, and they found that type 6 and type 11 they cause only genital warts, and they found that oncogenic virus type 16 and type 18, type 31 and 33, these are oncogenic viruses. How the virus affects the cell and how it is let this epithelium become carcinogenic or progress into cancer. The first step, the infection of the cell or the epithelium by the virus, this is step 1. And after that, the persistence of the virus for a long time, and this is affected by the immunity. Instead of clearing the virus, there is persistence of the virus. And after that, progress of the epithelium to precancerous lesion like CIN1, CIN3, and lastly, progression or development of invasive cancer. These are the steps of progression or develop cervical cancer after infection by human papilloma virus. Now let us talk about epidemiologic risk factors. I know there is some risk factors. They found that some risk factor and those more prone or they develop cervical cancer. These risk factor include multiple sexual partners, more than one, and promiscuous partners, age of first intercourse experience, early childbearing, high parity, prior sexually transmitted disease, and cigarette smoking. They found there is relation between cervical cancer and cigarette smoking. Also, oral contraceptive usage and intrauterine exposure to diethyl stilbestrol, and immunodeficiency. As I told in the previous lecture, immunodeficiency, this lead, instead of clearing of the human papilloma virus, lead to the persistence of the virus. This is one of the steps progression of cervical cancer. Cervical cancer, they found that it occur in different ages. Around 30 still carcinoma in situ, and around 51 years is invasive cervical cancer. Here you could see in this chart or diagram that number of cases, and this is per 100,000 female. It is increasing here up to 2030. Histological types. Squamous cell carcinoma is the common type, histological type of cervical cancer. After that, adenocarcinoma and adenosquamous carcinoma and malignant melanoma, and this is they are rare and not common. What is the clinical presentation of cervical cancer? Cervical cancer, the clinical picture, how the patient present with cervical cancer. First, sometimes some patient asymptomatic. You can these are early stages of CIN, and abnormal Pap smear can discover accidentally abnormal Pap smear, or some patient come with postcoital bleeding, intermenstrual bleeding, postmenopausal bleeding, or blood stained discharge. Sometimes in advanced stages, the cervical cancer present with pain or renal failure. The disease is often locally not visible, sometimes not visible. So we need for those patients with some symptoms or some sign of cervical cancer, we need speculum examination, and sometimes we could see a cervical mass or hardness and fixity of the tissue, and a biopsy in the outpatient should be taken. The diagnosis can be missed as some tumors are endophytic rather than exophytic. They found that some tumor, the growth of some tumor is inside the cervix. This is what we call endophytic. Some tumors are exophytic. This is clearly can be seen during speculum examination. Here, this is a picture of cervical cancer. Here also picture of cervical cancer. You could see here how edematous and how the blood vessels. What is the pathophysiology? The majority are squamous cell carcinoma, as I told before, and adenocarcinoma. Locally infiltrative in the pelvic area and spread via lymphatics and blood vessels. This carcinoma of cervix can spread through lymphatic and through blood vessels, and grow through the cervix to reach either parametria, bladder, vagina, and rectum. Parametria, this is a tissue around the vagina, spread locally from the cervix to the vagina to the parametria, and even can reach the bladder locally and reach the vagina, upper third, lower third, and can reach the rectum. Metastasis also, cervical cancer can metastasize to iliac, obturator, and para-aortic nodes, and in later stage, distal metastasis to the liver and even to the lung or the brain. What are the investigations needed to diagnose cervical cancer? Stage according to the system introduced by International Federation of Obstetrics and Gynecology, FIGO, yes, they said that cervical cancer staging is clinical. Clinical to take a biopsy and to do investigation and test X-ray or MRI so as to assess the local spread. After that, you stage the lesion. Here, this is MRI picture which shows cervical cancer. Investigation and staging and examination under anesthesia to know whether the tumor is operable. This is very important steps. And a rectovaginal examination, BR, to see the rectum is mobile or fixed. We need also cystoscopy to look for the bladder inside. And a small mobile tumor favor a surgical approach. Why staging is important? Clinical staging is important, so as important to decide about the treatment options, to select the suitable treatment for the stage of the cancer. Larger fixed tumor favor the use of radiotherapy. Small mobile favors the surgical treatment. The FIGO staging of the disease is based on the clinical, as I told you, on clinical finding, and this is why. Because radiotherapy is used in advanced disease, if we found that the disease is advanced, spread to some local spread and distal spread, only we will treat the patient by radiotherapy, as we will see in the next coming slides. Possible to stage patient in the developing world. Also, it is easy because, as I told you in the epidemiology of the disease, that cervical cancer is common in the developing country where the resource and investigation is not available. So, better to investigate and stage the tumor by clinical. So, it is easier to be staged in developing country. Let us talk about stages. The first stage of cervical cancer is stage 1A, carcinoma confined to the cervix. Stage 1A, this means that the tumor is still confined to the cervix. Corpus extension should be disregarded. This means that if you found the extension of the tumor from the cervix to the uterus, body of the uterus, this is not considered. It's considered only carcinoma of the cervix. Stage 1A identified microscopically and depth not more than 5 millimeter and not wider than 7 millimeter. This is stage 1A. It is not more than 5 millimeter and wider, depth not 5 from the basement membrane, not more than 5 millimeter and not wider than 7 millimeter. And they divide that stage 1A, as I told you, it is a microscopic stage, into stage 1A1 and stage A1-2. Again, they measure invasion not more than 3 millimeter in depth and not wider than 7 millimeter. This is stage 1A1. Stage 1A2 greater than 3 millimeter and still not more than 5 millimeter. Here I show you this picture. This is a cervical cancer, stage 1A1. As I told you here, stage 1A2. Both of stage 1A is not more than 5 millimeter and not more than 7 millimeter. In which stage 1A1 up to 3, not more than 3 millimeter, and stage 1A2 between 3 and 5 millimeter. Next stage is stage 1B. All gross lesions are stage 1B cancer. Gross lesion means that this lesion can be seen larger and either with bleeding, either with a mass. All gross lesions, these are, or with symptoms, these are considered as stage 1B cancer. Stage 1B, it is really a clinical lesion confined to the cervix. Still, we are inside the cervix, but it is a clinical lesion. Or preclinical lesion greater than 1A. Stage 1B1, this is a clinical lesion not greater than 4 centimeter in size. Stage 1B2, clinical lesion greater than 4 centimeters. This is stage 1B1, which we describe as clinical lesions and gross lesion. Here I show you this picture. You can see stage 1B1, 4 centimeter or smaller. Stage 1B2, larger than 4 centimeter. Stage 2. Here, carcinoma extending beyond the cervix. As I told you, stage 1, carcinoma is still inside the cervix. And it is staged or categorized according to the size of the tumor. Either microscopically, this is stage 1A, or gross lesion, clinical lesion, stage B. Stage 1 up to 5 millimeter and 5 by 7, this is stage 1A. Stage B, 4, more than 4, less than 4. Stage 2, this carcinoma extending beyond the cervix and involving the vagina, but not the lower third. It is only involving the upper two-thirds. And in the upper two-thirds, it either infiltrates to the parametrium or is still inside the vagina. So stage 2 also is divided into 2 stages, stage 2A and 2B. 2A carcinoma has involved the vagina only, not extending to the parametrium. Stage 2B carcinoma has infiltrated the parametrium. The parametrium is the tissue around the vagina. Parametrium around the vagina. Here, this is a picture, stage 1, stage 2A and stage 2B. You could see in the picture to the right is still the cervix outside the vagina, but extend to the parametrium. The picture to the left, you could see the picture to the base, the tumor. It is stage. Here in the picture to the left, you can see stage 2B, and the picture to the right is stage 2A. You could see that the carcinoma extend outside the cervix, invading the upper third of the vagina, but it's not by invading the parametrium. And the picture to the left of the screen here, carcinoma has invaded even the parametrium. Stage 3 carcinoma involving the lower third of the vagina or extending to the pelvic side wall. There is no free space between the tumor and the pelvic side wall. Here the tumor pass or invade from upper third of the two thirds of the vagina to the lower third, but to the lower third also divided into two, 3A, 3B. 3A is still in the lower third, but not reaching the pelvic side wall. 3B, lower third of the vagina and extending to the pelvic side wall, and this is one of the most important stages which can affect the kidneys and affect the ureter, and the patient can present with renal failure or some problem in the kidneys. This is a picture here. You see stage 3A and 3B. 3A is the picture to the left, involving the lower third of the vagina, but not extending to the pelvic side wall. Here, the picture to the right, extending to the pelvic side wall, affecting the kidney. Stage 4, this is a distal metastasis and carcinoma involving the either 4A and 4B. 4A, the carcinoma extend locally extension and not inside, still inside the pelvis. Carcinoma is still inside the pelvis, and it affects either the bladder or the rectum. Stage 4B, this is spread to the distant organ like liver, brain, and lung. Here, this is a picture show you distal metastasis, either local for bladder and rectum or to the lung and the brain. Diagnosis: how we could diagnose cervical cancer. First step by or one of the methods to diagnose or investigation to diagnose is colposcopy, then histology. Colposcopy, you can see in cervix. Colposcopy means that look for the cervix and you can see abnormal blood vessels, or this abnormal blood vessel either reticular, branching, variable, and loop with a variable caliber. This is abnormal blood vessel. You can see it in colposcopy. Also, irregular surface. You can see irregular surface. Cervix is not regular, and some ulceration. And the color also of the cervix is red and fungatus like, and like some pus on the cervix like that. This diagnosis can be done by colposcopy. Again, also you can take some biopsy and send for histopathology for the final diagnosis. Here, this is a colposcopic appearance of microinvasive carcinoma. You could see here in the upper picture varicose vascular abnormalities with punctuation, and also there is surface irregularity here in the lower picture. This also you can see in details in colposcopic workshop. Metastasis, either by direct spread to distant tissue, like as I told before, cervical stroma, and parametrium and beyond. Or spread also can occur by lymphatic. This can to the pelvic side wall lymph nodes and para-aortic lymph nodes, and also spread can occur by blood to distal organ. But usually or fortunately, spread by blood in cervical cancer is unusual and rare. Lymph node metastasis, first they metastasize to obturator lymph node and internal iliac, and sometimes go to iliac, external iliac, sacral lymph nodes, common iliac, and lastly they can metastasize to the para-aortic lymph nodes. Here this is a picture, shows the spread by lymphatics, aortic, common iliac, external iliac, obturator, internal iliac. Here this table shows the chance of lymphatic spread according to the stage. Lymphatic spread is important in the management and in the treatment and in the this incidence here, incidence of nodal disease in cervical cancer according to stages. As you could see here, stage 1A1, this is less than 1 millimeter, or stage A1 less than or 1.3 millimeter, the chance of pelvic node is 0, and para-aortic node here is 0. This lead to prognosis is good here after you treat the patient surgically, and the chance of prognosis is good because you clear the cancer completely and there is no lymph node involvement. Factors that influence prognosis. What are the factors? The stages of the disease. The stages of the cervical cancer. This is one of the most important factors that affect the prognosis. Those who come with late disease, stages involving lymph node, and those are staging involve more tissues and distal metastasis, the prognosis is very low. Another thing is the volume of the disease. If it is small or it is large. Grade of the tumor, well differentiated or less differentiated. And the histological type, this also affects the prognosis, either squamous or adenocarcinoma, lymphatic spread, and vascular invasion. Here, this is a survival year according to the stages. Stage 1, 83% survival for 5 years. Stage 2, 65%. Stage 3, 36%. And for stage 4, only 10% those who can live for survival age for 5 years. What is the treatment of cervical cancer? You know, treatment depending on the stage of the disease is one of the most important factors is the stage of the disease. And according to the stage of the disease, you can choose or select the modality of treatment you can give to this patient or how you can treat this patient. Another thing is the age and stage and the fitness of the patient. If the patient is too old, unfit for surgery, then you can state other modality of treatment like radiotherapy. And treatment should be discussed in multidisciplinary team of doctors. Those are other doctors and involved like radiotherapist and also surgeon, radiotherapist, radiologist, and pathologist and nurses. So when you want to treat a patient with cervical cancer, after you stage the cancer and your investigation, you need to make a multidisciplinary team and to decide about the optimum or the best treatment for the clinic for the this patient. Now, preclinical lesion. Preclinical lesion, as I explained in the previous, this microscopic lesion like stage 1A, all these are microscopic tumor, and this microscopic tumor have a low volume of cancer and are usually picked up as incidental finding after loop dithyramine. For some reason, accidentally, you remove those who are doing colposcopy or those who are routine investigation or screening for cervical cancer, you discover a lesion, and when you remove it, send for histopathology, then you discover there is clinical or there is a microscopic tumor. A small lesion need to have a clear margin for excision. After you remove or excise the tumor, then you found under histological examination the tumor margin is clear. The biopsy margin is clear from malignant cancer. Here, this means that you remove all lesion. You remove all lesions, so no need for further treatment. This is for stage 1A, and those with preclinical lesion is still less than 5 millimeter and less than 7 millimeter in the width. If the pre-invasive disease is not completely excised, repeat the excision. If you discover that this is preclinical lesion, but the margin is not clear, so you need to repeat excision and remove the rest of the lesion. So you clear the cervix completely from this microscopic lesion. Lymph adenectomy considered for stage 1A2. If we discover that stage 1A2, this is a lesion, microscopic lesion, more than up to 5 millimeter and more than 7 millimeter. This can we consider, but in stage A1, stage 1A1, this is up to 3 millimeter and in 7 millimeter width. This most probably the involvement of lymph node, as I told you in that table, is 0. So no need to do lymph adenectomy. But in this stage, stage 1A2, the lesion here is up to 5 millimeter. The depth of the lesion is up to 5 millimeter. And as you saw in that table, the involvement of lymph node, pelvic lymph node, there is a chance of involvement of pelvic lymph node, and so we need to consider lymph adenectomy for good progress and for good prognosis. This treatment enables fertility because everything is cervix is available, uterus is available and not removed, and hysterectomy is not necessary if margin is clear. No need to remove the uterus. Also, but in certain cases can be considered so as to for better prognosis. We need to remove hysterectomy if say that the mother or the woman complete her family and she doesn't need further children. We can consider here hysterectomy. This is an example. Fertility preserving treatment is not an option because large volume tumor, this is stage 1B. That stage 1A, that microscopic, we finished regarding treatment. Stage 1B, this is what we call, it is a clinical lesion, and the lesion is large volume. So fertility preserving, what is fertility preserving? Fertility preserving, this means to remove the cervix and allow the uterus for further pregnancy. And we also in premenopausal patient consider radical hysterectomy and pelvic node dissection, Versailles hysterectomy, and preserve the ovaries. Here in this stage, because it is a large volume, we need to do Versailles hysterectomy. We remove, in those premenopausal women, we remove all the uterus, tissues, lymph node, cervix, vagina, everything, but we leave the ovaries because the woman is still young. Pelvic radiotherapy has similar success rate as surgery in early stage 1P. Here also this is a very important point. Both in stage 1B, you remember stage 1B, both surgery and radiotherapy has a similar success in prognosis. So we can consider in radiotherapy in premenopausal patient with unfit, like overweight or unfit for surgery, or in postmenopausal patient because urological complication is high. Those who are unfit and elder patient, better to do radiotherapy because both radiotherapy and surgery similar success. Fertility sparing treatment, radical trachelectomy. This is what I mentioned before. Can be considered in small volume. What is fertility sparing treatment? Fertility sparing treatment means that to remove only the cervix. Remove only the cervix and allow the uterus because the mother or the woman want children. This is fertility sparing treatment. This type of treatment is suitable for early stage small tumor in stage 1B1 and outside stage 1A2. Outside stage 1A2 and in stage 1B1. Stage 1B1 less than 4 centimeter. This is less than 4 centimeters, stage 1B1. So here the treatment of fertility sparing is suitable for these stages. Radical trachelectomy means what we call fertility sparing treatment, is removing 80% of the cervix and the parametrial tissue. Remove all parametrial tissue around the cervix, resection of the pelvic lymph nodes. Also, the chance of metastasis of lymph nodes is high, so you remove the nodes. But this type of treatment has some complication, and mid-trimesteric miscarriage rate can be as high as 40%. The risk after you remove the cervix, there is a chance after the woman becomes pregnant, there is a chance of miscarriage at around 40%. So you should counsel the patient about the risk and benefit of this type of treatment. Radiotherapy. Radiotherapy with or without chemotherapy is optimal in stage 2 and 4. Here, stage 2 and 4, because the late stage of the disease and the disease is spread and even lymph node involved, even whatever you do by surgery, you cannot clear the tumor. So you need to do radiotherapy. Surgery not advised because severe hemorrhage during operation, because this carcinoma, spread to other tissues and the tissue fixed. So, when you remove the tissue, there is more bleeding. You cannot control bleeding during operation. And also, clearance of the tumor is unlikely because it is spread to other either para-aortic lymph node, which is very difficult to remove it. And incomplete excision need post-operative radiotherapy, which can lead to high complication rate. Incomplete, you cannot remove all the tumor, so you need again radiotherapy. The standard surgical operation for stage 1B tumor is, before, if we select surgery or radical hysterectomy and pelvic node dissection, which include surgical treatment, removal of the cervix, removal upper third of the vagina, removal of the uterus, parametrial tissue, pelvic node removal, all pelvic lymph node removal, obturator, internal, external, iliac nodes. This is what we call radical hysterectomy. You remove all these tissues, including the uterus, including the cervix, including the parametrial tissue, and you remove all this. This type of treatment has good prognosis but has some complication. The ovaries in premenopausal women can be spared. In this treatment, you leave the ovary. And what are the complications of such type of treatment? Morbidity in this procedure, like bladder dysfunction, because you remove nerves around the bladder. Sexual dysfunction, lymphedema. Why? Because you remove lymph nodes. Radiotherapy. What is the meaning? Radiotherapy means that instead of surgery, in some stages need radiotherapy. So we deliver a lethal dose of radiation to the tumor, and minimize damage to the surrounding tissue. This is the aim of radiotherapy. Generally, in every cancer, when you select to treat this tumor by radiation, you deliver a dose, lethal dose, to destroy or damage the cervical and to preserve the normal tissue. Treatment is overseen by radiologists, and treatment is delivered in 2 ways, either by external beam or internal radiotherapy. In external beam radiotherapy, the source of the radiation is from a machine called linear accelerator. Here, this is a picture of linear accelerator. What are the complications of radiotherapy? Bowel and bladder urgency, skin erythema, vaginal stenosis, sexual pain, cystitis like symptoms, hematuria, malabsorption, and radiotherapy induced menopause because it can affect the ovaries. Radiation can affect the ovaries and can lead to menopause. Chemoradiation, this chemotherapy, what we call chemotherapy, like cisplatin, is ideally given in conjunction with radiotherapy, as this combination increases cure rates. There is now international acceptance that chemoradiation is the treatment of choice for advanced cervical cancer. They found that chemotherapy is one of the best treatment for radiation. Palliative treatment. What is a palliative treatment? Palliative treatment means you need to improve the quality of life of the patient. When it is not possible to offer curative treatment, then palliation of symptoms becomes important, and early involvement of the palliative care team is essential for symptom controls. If she has pain, treat the pain. Bleeding, treat the bleeding. Anemia, treat anemia. Malignant pain, recto and or vesical vaginal fistulae and bleeding may occur. Radiotherapy may be considered with palliative intent. If you need radiation for palliative treatment, you can offer to the patient. So palliative treatment is one of the, when the cervical cancer in the late stages, you cannot do surgical, you cannot do anything, so you treat only in all cancer. Palliative treatment means that you improve the quality of life and you treat the symptoms. Whatever the symptom appear, you treat that symptoms. Recurrent cervical cancer. This means that if you give or you offer the patient or you give, you treat the cancer with cervical cancer either surgically or radiotherapy or anything, then after some times the patient came again with recurrence of the cervix of the cancer. Treatment of recurrence depends on the mode of primary therapy and the site of recurrence. What type of treatment the patient given and what the site of recurrence. This means that women who have initial treatment by surgery should be considered for radiotherapy, and those who are the first treatment by radiotherapy should be considered for, provided the recurrence is central and there is no evidence of distant recurrence. Now I come to my conclusion of this lecture. Cervical cancer is common in the developing world, as we told in the first slide. Population-based cervical screening of adult women has prevented 70% of cases of cervical cancer that is developed in United Kingdom. And all patients with symptoms of cervical cancer should have a full pelvic examination. For further reading and for all more information, you can go through this reference. Thank you for your watching. Thank you very much. See you in the next lecture.